Hi, everyone. Welcome to our fourth session of the Prematurity Prevention Initiative Summer Speaker Series. We are so excited to have you on this call today, and we have a great panel for you all to talk about Black breastfeeding. So before we get started, I'll just share a little bit about the Prematurity Prevention Initiative and who we are, what we do. So the Prematurity Prevention Initiative is a collaborative cross-sectional effort aimed at focusing community engagement on available evidence-based interventions. And the goal is to reduce preterm birth rates in New Jersey. So today, my name is Casey Mile. I am the education coordinator for the Prematurity Prevention Initiative, or PPI as we call it. And I'm at the Partnership for Maternal and Child Health of Northern New Jersey. And I will be one of the moderators today, along with my colleague, Christine Ivory, who will introduce herself in a few minutes. But before we get started, to shake things up a little bit and have a casual conversation and check in, we just want to start with our panelists sharing what is our favorite summer activity. So I'll start. My favorite summer activity, I love going to the beach. I love being in pools. And, unfortunately, I didn't do too much of that this summer, but I have hope for future times. So Christine, I'll turn it over to you.
Sure. Hi, everyone. My name is Christine Ivory, and I'm a health educator also for the Prematurity Prevention Initiative at Family Health Initiatives. And I would say my favorite summer activity also is a lot of beaching as well. However, didn't get there yet. I have developed a new activity, though, which is hiking. So I'm loving that, and I'm going to pass it over to Nasheeda.
Hi, my name is Nasheeda, and I am a health educator and certified lactation counselor at the Southern New Jersey Perinatal Cooperative. And I would say my favorite thing to do is just being with my children. I've had the opportunity to spend lots of time with them this year, more than probably years before, but it's been unique. So I'll pass it to Nastassia.
Hi, everyone. I am Dr. Nastassia Davis. I am the founder and executive director of the Perinatal Health Equity Foundation and also assistant professor of nursing at Montclair State University. I'm an IBCLC and a registered nurse. And I would say my favorite summer activity is definitely spending time with the kids. We like to be out going to the boardwalk. We didn't get to the boardwalk yet this year. The day we had planned, it rained. So we haven't been there yet, but definitely like to be out and about with the kids.
Sounds great. So thank you, everyone, for your introductions. Thank you, Nasheeda and Dr. Davis, for being on the line with us this afternoon. Let's get it kicked off with our question. So our first one is, what is Black breastfeeding, and why is it significant compared to other races?
Who do you want to take it?
Oh, I apologize. Let's start with Dr. Davis.
So I would say Black breastfeeding isn't different than it is for anybody else. I would say our challenges are different. The act of breastfeeding is breastfeeding. But I would say that there is a story that comes with Black breastfeeding, especially Black American breastfeeding, with its connection to slavery and wet nursing that is very different than Black breastfeeding that may be experienced, for example, in countries in Africa, for example. Our story is a little bit different in that bodily autonomy was taken from us at the beginning of that. We were forced to wet nurse the slave master's children while we left our children behind to die, essentially. Once we were able to move past that, we then had formula marketing that was targeted specifically to the Black community. Once the Black community began to establish itself and had money and was considered to be a target audience, we were targeted specifically. And you can look at the Fault Squad as an example of what that marketing looked like. They did the pet milk campaigns. They were the first set of Black surviving quadruplets, all of which unfortunately passed away from breast cancer. But there is a lot of history that comes with sexual trauma, for example, that's connected to low breastfeeding rates. And then also just a lack of support. Just really not believing in Black women's ability to breastfeed. So it's not even discussed. So there's a lot of lack of support and education, both on the provider side and on the family side. So there's a very sullied story when it comes to Black breastfeeding.
Thank you, Dr. Davis, and providing that historical context also as well. Nasheeda, I want to hear from you. Can you tell us about why is breastfeeding or Black breastfeeding significant in our community?
A lot to what Dr. Davis said, but to add to that, I'm just thinking about our infant maternal and maternal mortality rates within our communities, our access to health care and our access to healthy foods all have and play a significant role in breastfeeding. And so when we talk about all of these different things, it's really important for us to recognize that and also understand that we need, or our needs is a little bit specific when we're talking about all of those things that we have to unpack. So it's important for us to really focus on those things and then provide space for people, Black and Brown, to be able to talk about some of those historical traumas. One thing that I want to add, as far as like Black Breastfeeding Week, is really important, and I'm so thankful for it because it helps to uplift and celebrate our women and people of color.
And I'd like to add too that often when we talk about Black Breastfeeding Week or things that are advertised for Black people specifically, segregation comes up a lot as to why are we creating a further divide by just talking about Black issues. And the reality is we have to really put the attention where the problems are occurring. And I need people to understand that it's not a divisive platform. It is not meant to separate people, but it is meant to shine a light on where there is a problem. And there are problems in the Black community when it comes to breastfeeding initiation. Our rates are lower than anybody else. Hispanic women and Asian women actually have very high breastfeeding rates. And so although there might be other minority groups that exist, but if you look at Black African Americans and also the Indigenous community, there are a lot of disparities there. We're just coming out of Indigenous Breastfeeding Week, and I want to just uplift that as well. But it's not meant to divide anyone. It's meant to talk about where the issues are so that help can be provided.
Absolutely, and thank you, Nasheeda and Dr. Davis, both for sharing that context as well as about Black Breastfeeding Week. I know Christine and I talk a lot about the racial disparities that we face, even sharing information about preterm birth. So we really wanted to highlight Black breastfeeding as part of that. So thank you. I hope everyone listening can gain something from that answer, as well as knowing why we're here, and whether they are a Black provider or a mom themselves, or just learning more about Black breastfeeding. I think it will be really helpful today. So I want to go on to our next question. What are the benefits of breastfeeding? And can you tell us a little bit more about if somebody wants to breastfeed, what could they benefit from, both either mom, the pregnant person deciding this, or the baby? And Nasheeda, let's start with you.
Sure. So as far as when it comes to a baby, there's a lot of different benefits. So thinking about how it can help with increasing, or not, I shouldn't say increasing, well, building the immune system. So a baby's immune system, but also helping to fight off germs, decreasing the risk of sudden infant death syndrome, SIDS, which is the babies dying in their sleep unexpectedly within that first year of life. It also helps with reducing certain illnesses and diseases. And then when we're talking about birthing people, there's decreased chances of different breast cancers and ovarian cancers, as well as helping with osteoporosis and reducing that.
Awesome, thank you. Sounds like a lot of great benefits for breastfeeding. And Dr. Davis, did you have anything to add to that?
Sure. I think one thing I've learned very early on in my breastfeeding career is looking at breast milk and human milk as the normative method of feeding babies. And not that formula doesn't have its place, because that often comes up as lot, that when we celebrate breastfeeding, that we are somehow shaming women who formula feed, and that's not the case. But our bodies were designed to provide human milk. And so it's not that there is really a specific benefit to breastfeeding, it's what the baby's supposed to get, right? So if you're looking at post-birth, there is decreased risk for hemorrhage because breastfeeding naturally reduces or releases oxytocin, which helps to contract down the uterus, so that can control some bleeding. Thank you, Nasheeda, for mentioning breast cancer. When we talk about Breast Cancer Month, breastfeeding is never discussed as a preventative measure, but the duration in which a breastfeeding person breastfeeds, the longer cumulative months that you've breastfed, the decreased risk there is for developing breast cancer. But then also looking at babies, especially our premature babies, who are more at risk for developing necrotizing enterocolitis. So the earlier the babies are, the more at risk they are for develop that. And basically that is a condition in which there is death inside the GI system. And so when babies receive human milk, they are less likely to develop those bad bacteria that lead to necrotizing enterocolitis. I definitely credit my breast milk with getting my premature baby out the NICU a lot faster. She was a 34-weeker. She was my preemie, my only preemie. And I was thankful that I was able to give human milk to her so that she did not get sick and she didn't have a prolonged stay in the NICU. But also looking at other things that keep babies in the hospital. So hypoglycemia is another one. We know that breast milk better stabilizes glucoses over formula. We also know with hyperbilirubinemia, premature babies are especially at risk for that. Breast milk provides the ability for babies to stool and void a lot more frequently, which is going to get rid of the billy and get them out of the hospital a lot faster. So if we can avoid doing phototherapy and separating parents from their babies, that's ideal. There are a number of benefits that, especially when it comes to communities that have high risk for asthma, for example. Black communities tend to have more cases of asthma than other communities. We know that there is a reductive factor there. And the other thing is when we're looking at eczema, there is also a huge push in people looking at dietary concerns when it comes to eczema, but we know that the first bacteria and gut bacteria that grows has a lot to do with how that happens. And formula just causes our guts to grow a different bacteria, whereas human milk grows good bacteria. So less likely to develop food allergies and things like that, which is where eczema typically comes from.
That's awesome. Thank you for sharing, Dr. Davis, and also Nasheeda. There's so many benefits, not just to baby, but also to mom as well. So thank you for sharing all that. For our next question, we want to know, what challenges do moms and pregnant people face with breastfeeding, and how do you feel that the state of New Jersey is helping to overcome these challenges? And I'll start with Nasheeda.
Okay, so a lot of the challenges that I've seen for some moms is some of what Dr. Davis mentioned earlier as far as lack of support. So when I say lack of support, I'm talking about within the community and return to work. So some of those examples of people having to return to work a lot sooner are African American women. And then when they do have to go back to work, a lot of times that means that whether they were pumping or if they were breastfeeding, a lot of that sometimes is decreased or shortened. I'm talking about lack of support from sometimes family and friends. And what that may mean is negative beliefs or attitudes towards breastfeeding that can impact a person's decisions on if they continue with breastfeeding or not. And then also talking about providers. So whether they're providing lack of breastfeeding education prenatally or none at all, because I've had those experiences with some moms who have said that they didn't receive any education. And when it is, sometimes it's the access to lactation professionals that look like them. And myself, moving towards becoming a lactation consultant and on a pathway, I recognize the need for more Black lactation professionals in this field, because a lot of times when you are in these places and some people do have biases. We want to really try to address that by, having people who look like them that represent those communities. So when we're talking about lack of support, there is a variety of things. But then what are some of the things New Jersey is doing? So one of the things that I remember happening in the beginning of the year is a legislative package that was signed to help to include breastfeeding being covered through certain, Medicaid as well as insurances. Other things is the New Jersey Breastfeeding the steering committee. So the steering committee of New Jersey really had done a lot of focus groups throughout the state, collecting information to really understand, the different needs throughout the state and then turning that into recommendations. So although those recommendations haven't been put out yet, that is something that the state has been working towards. And then I can also speak for the agency that I work for in particular, and we've been doing some internal focus groups to help collect information to help assess where we need improvement, because we do provide a lot of home visiting programs to people in South Jersey. So making sure that we have that information available in the training and making sure that the staff that are a part of the agency are up to date with breastfeeding resources is important.
Thank you, Nasheeda, for sharing that and speaking to support implicit bias or those unchecked biases. And also saying a little bit about what New Jersey's doing. It's great to see how we're progressing. Dr. Davis, do you have anything that you'd like to add?
Sure. Like as far as barriers go, I would honestly say formula is a huge barrier to breastfeeding success. We cannot solve breastfeeding issues with saying give formula. That can't be the rationale. We need to do a better job with providing people with resources that are equitable and accessible. I find that a lot of families at the time of discharge are not given any resources for where they can follow up with if they don't have support, but they are given formula. So our discharge bags have disappeared, but they have been replaced with discharge bags. And I know a lot of people do it as a mechanism to sort of safeguard the baby, but it also sends the message that there's failure impending. And so when it does, here's your backup. And that message is very negative. And it also is damaging where there's already a sense of doubt with women's ability to breastfeed. And this is just in general, most birthing people have that type of experience with breastfeeding because you can't see the milk. So it sets up for that thought that, this might not work, this might not be successful. And so here's your formula for when that happens. So I think that's very negative messaging. I also think we need to look at learning better where the community resources are. Myself, I run a breastfeeding support group, Sisters Who Breastfeed. There's also Chocolate Milk Cafe, who caters to Black communities. And I think providers and hospitals need to do a better job with sending out that information to families so that they have access to it. But then also looking at what are the other community resources and organizations that are supporting breastfeeding in general that may not necessarily be WIC. Because WIC is often, and this is an indicator of bias, and people may not mean to do it, but saying as a Black woman, go to WIC, is an assumption that they qualify for it, number one, and two, that that's where they need to go for support. Not every Black woman is a low-income Black woman, and I really need to make that distinction that's a narrative that needs to be discontinued. We are a variety of different incomes and education levels, and we need to be treated as such. WIC is not going to cover everyone. So in the event that this person can't go to WIC, where else can they go? So providing those resources, but then also prenatally starting that conversation about not what formula are you going to give, because that's often how it's phrased, but how are you choosing to feed your baby, and let the client give you back the information about what it is they plan to do, and then have a conversation. Don't just say, oh, you're going to formula feed. Okay, check, the end. You need to have a conversation about why they're choosing that. And I find that most often when you speak to families about their feeding choices, you get to the root of why they've said they want to formula feed. Well, my last baby, I had such a hard time breastfeeding and they ended up in the hospital, so I didn't want to do that again with this baby. Or, my aunt had a very bad experience breastfeeding. Or you might hear, I was sexually abused and I don't feel comfortable with having a baby on my breast. These are conversations that we need to be able to have with our families, and all rooted in trauma-informed care. But I think we need to not just accept things at the face value, but have conversations, and not in a way that's pushing. And I will say that's another thing that came back in my own personal experience, that when we talk about breastfeeding, it sometimes comes off as being forceful. that someone must do it. And I don't think that's anyone's intention, is to make people breastfeed. We want people to have the education to make informed decisions, but we also need to respect them once they've been made. And I think as far as what New Jersey's done, I'll say from my own work with the state, I am part of a couple of the Healthy Women, Healthy Families grants. And so the work in trying to get the support groups off the ground has definitely been a long road, and trying to get people engaged and involved in those groups. But where we're making headway, our groups grow every day. So we have a chapter that covers Jersey City and Patterson, and then we also have a chapter that covers South Jersey and the Camden County area. And having Black leaders in those groups, I think, is really important. And not only are they Black leaders, but they are members of the community, which matters as well.
Yes, absolutely. Thank you, Dr. Davis, for not only sharing those resources, but really highlighting that we need to have these conversations as, providers, practitioners, even families that support our moms and pregnant people. So thank you for outlining that.
Yeah, I'll second that, Christine, and also Dr. Davis, of really making it focused on the birthing person and the individualized needs. I think that all of that sounds really important and for support. I'd like to follow up on what you said a little bit about earlier, because you mentioned a lot of barriers there, but one specifically that I'm curious about is with somebody who has a baby in the NICU. That seems like it might present even further barriers if they do want to provide breast milk for their baby. Could you talk maybe a little bit about, are there options for that person if they find themselves in that situation? And if so, how can they get support?
Absolutely. There are definitely some challenges, and I don't think I appreciated those challenges fully until I had to experience it myself. I've built lots of care plans for NICU families and said, you need to pump 8 to 10 times a day, you need to do this and you do that. And when I had to actually do it myself, I realized how difficult it truly is to be an exclusive pumping parent. It's not an impossible feat, but it is a lot of work. And so I think doing things to provide access. So when we talk about equity, for example, when we're looking at Medicaid plans that provide breastfeeding support, the pump options are limited compared to commercial plans. And so if you're getting a pump that isn't as high quality, and that's your only lifeline to your supply, you're not going to be successful. When we look at hospitals that provide rental stations, are they providing discounted rates for families that can't afford it? Because renting a pump is very, very expensive. And so if you don't have access to something that is either hospital grade or comparable, like a Spectra, for example, it is very difficult to initiate a supply. But there are resources that can help to support those families in getting those things. And we have to do a better job with aligning families with those resources. The other thing I would say is we're actually going to be doing a talk about community milk sharing with Hakima Payne, who runs a community milk bank out of Kansas. And so I think when we look at donor milk and peer-to-peer milk sharing and things like that, we have to also break down some of the stigmas that come with that, and being able to have open conversations about what that is and what its purpose is and how it's beneficial. I know that there is new coverage for donor milk through Medicaid, and I haven't quite found my way through how families are able to access that support. And I think the other issue is, as we roll out these new policies and new laws, we need to have guidance for the providers to be able to help the families with them. So right now, I know that Medicaid covers donor milk. I do not know how to get donor milk covered from Medicaid to a family. So we have to do a better job with being very clear with the resources that we provide so that people can access them. So donor milk is another supplemental program, but then also having someone that specializes in NICU working with those families, because it is a very different experience, making sure that we understand that skin to skin is important in that time period, and that regardless of whether the baby has tubes or IVs, that skin to skin is still possible and can be done safely. Dr. Nils Bergman has done a number of studies on that and has actually come to several NICUs that I've been at and demonstrated doing it with very early babies safely. So I think a lot of the staff needs to work on education and removing some of the fear of being able to do that, because often families are just told no, that they can't do it, when in fact they can. It's just that hospital chooses not to offer it. The other thing is that there is no requirement that a baby must bottle feed before they can breastfeed. That has become hospital policy in many places, but it's not evidence-based. And so what it does is create babies who end up maybe very well able to take a bottle, but never been to breast. And so when that family goes home, they're trying to breastfeed for the first time by themselves. And so they're not successful. So we have to teach families that those are options for them, and push for them in the hospital so that they can have access to the breast and start that journey in the hospital, and give them the supportive tools they need. If they need a nipple shield, do they have access to them? If they need a pump, do they have access to it? And so I think we just have to really work with families and find out what their needs are so that we can better support them. It's not an impossible task, but we put up a lot of barriers that make it impossible.
That all sounds important. And, honestly, a lot of that sounds like something you probably wouldn't think about unless, like you said, you either are in that situation or you work every day in that specific setting. So I think, finding those supports is very important. And I know that also came up, Christine, that came up on our last Q&A session as well, right? With, we had some moms on a panel who had a previous preterm birth, and they were sharing their experience surrounding wanting to breastfeed and intuitively feeling like that was really best for their baby at that time, and being told that, this is not an option for them. And, we talk about advocacy or what that looks like in that situation. So, and the sharing of breast milk and all of that. So thank you for sharing. And Nasheeda, did you have anything that you wanted to add on to that?
I think that Dr. Davis said a lot. The only thing that I was thinking about, as far as it was a lot of information that I think that people need to hear, especially touching on milk sharing, because a lot of times when we hear these things, one, people don't even always know that that's a possibility, or they never thought of it in that way. So to have the conversation to begin talking about, you have options, and to learn those options is really important, because then that helps to empower those families, because then it allows them to be able to make the decisions for themselves and not necessarily someone else making them for you. And I think that brings that back. And that makes me think about this year's theme for Black Breastfeeding Week, and talk about that portion of reclaiming it. Like, this is my choice and my decision. And so allowing people the opportunity to get the education or to learn it, and then also receive the support around it, is really crucial. I myself did not have any experiences with a NICU or babies being born, my baby being born in the NICU, but I know so many moms who have. And I think it's very important to make sure that they have the support that they need, because we already know breastfeeding is really challenging. And that right there is a whole nother level. And I think it's important to be able to have that information to share with moms and families.
Yes, I was an IBCLC when I had my baby, and it was hard for me. So I can only imagine not having any of that knowledge and then trying to breastfeed at home. It seems really, really challenging. And it took us, she was born at 34 weeks and she's 6 now, she's thriving, but it took us 3 months to physically get her to the breast. That's when she was ready. And if I was not persistent every day with making sure that I put her to the breast, it would have been very easy to just let that go. And so if you don't have that experience and no one's there to tell you that this is what it might look like, a lot of people think that because breastfeeding is natural, that it's easy, and it's not. Breastfeeding is hard. It's a lot of work. And I think we don't tout it that way enough. Not hard to a point where it's not impossible, but when challenges come up, it needs to be understood that for most people, these are things that are normal parts of breastfeeding that do happen, and there is a pathway through it. But if people look at it and it said, I thought I was going to have this baby and they were going to go right to breast and breastfeed, and that didn't happen, and I had to give formula for 2 days, and so now the baby has gotten used for the bottle, and now when I try to put them on my breast, I can't. So now I just continue to bottle feed. This is the cycle for many families, and they need support to be able to break that down, that you can take a baby off a bottle and get them back to breast, but you need someone who has experience in doing that to help you. And if you don't have the ability, like right now, I know we've passed some legislation, but if you don't have Aetna or AmeriHealth, you are not getting an IBCLC unless you want to pay for it out of pocket. And so where do those families go for support? So I think we've done some things, but we've still got a lot of work to do. In addition to that, coverage for the pumps. Many of those NICU families need rentals. And so if you don't have a plan that will allow you to submit a prescription for a rental, then you're not going to get one either. And so that we really have to do more work with getting the resources to the families.
Thank you, Dr. Davis, for sharing some of your story, and then really both of you for highlighting the really important parts of advocacy and empowering, moms and birthing people. Really appreciate that. Our next question is something I was actually talking to Casey about. So I personally live in Philadelphia, and I drive frequently on the 95. So as I'm driving along, I see a huge billboard of a mom breastfeeding her child. And, really the statement, I guess, is to, as we're talking about normalizing breastfeeding and we're talking about Black breastfeeding, right? So what do you think New Jersey is doing in this sense to help to normalize breastfeeding, and what type of trends and what are you seeing right now? And I'll start with Dr. Davis.
I know exactly what you're talking about now, and I know Vanessa Simmons did that work. She's amazing. I know Philly got a big grant to do that advertisement. I think that's one of the things that we're working against, especially when it comes to formula. Formula has a huge pocket to do advertising and commercials. We don't have commercials and advertising for breastfeeding, and I think that is a weak spot. One of the things that I identified in my research in New Jersey, talking to Black families, is the lack of imagery. Even when it comes to discharge papers or videos that we might share, if you don't see yourself in the images, it's very hard to envision it as something that you could possibly be doing. So when you go into the hospital, who is hanging on the wall when you walk into the unit? If you see any breastfeeding advertised at all, it is not typically of Black families. When you get little pamphlets and guides on breastfeeding, who's on the cover of it typically? Not Black families. And so when you don't see yourself in the mission, then it really seems like it's not for you. And that's also been, a common thing. It's less said now, but breastfeeding has always been known as that's a white thing to do. And so the more you keep pushing that narrative and not showing Black families doing it, it makes it become true. Well, this is not for me because clearly my grandmother didn't do it, my mother didn't do it, my sister didn't do it, my best friend didn't do it. So not only are you not seeing it publicly, but you're not seeing it within your own circles either. And so then you don't have traditionally what you would have is you can go to your mom and say, you know what, I'm breastfeeding, I need some support, or someone close to you would typically be the person that helps you. Black families don't have that. And so most Black women are first generation breastfeeders. And so that imagery is very important. So I would say that that's a weak spot in our state. I don't think that we have enough visual images of Black women breastfeeding. And I think there's a movement with some colleagues of mine of Breastfeeding 365. And it really talks about moving Black breastfeeding as a conversation that's beyond just Black Breastfeeding Week, but that these are conversations that we're having all the time, because this is an issue every day of the year, not just during Black Breastfeeding Week. And it's a conversation that we need to keep having. And so the images are wonderful to see during Black Breastfeeding Week, but we need to continue to see them throughout the year.
Thank you, Dr. Davis. And like you said, it's super important that we have that representation of Black moms breastfeeding, whether we're at our providers' offices or wherever we're at in the world, so that we know that it's something normal, that's something that we could all do. I want to hear from you, Nasheeda. Do you have anything to add to that about normalizing breastfeeding specifically to Black women or Black pregnant people?
I was gonna say, I love that campaign. When I saw it, I was just like, yes, because I honestly, it's just so great to see. Like Dr. Davis said, it's like when you don't really see those experiences and you don't really see it, because we know that it is happening, but to really have that opportunity to uplift and to show and to encourage people in a whole nother way than before. Is really important. So this year, I do know that one of the things that we tried to do was collect images to share with and share on our social media of people of color in our communities around breastfeeding and why they chose to breastfeed. But I really think going back to talking about the images and why it's important is because it's all a part of that marketing, right? And really playing a role in like how we are viewed in society as a whole. So I think that in order for us to begin to really change the narrative on that, we need to go in purposely and focus on what it is that we want to be shared and how we want to be viewed. And I think that in order for us to do that, it's going to take a lot of work, but it also means that we do it. And so with that being said, I think that that's the opportunity maybe for us to do something even further next year with including those images. Because I will say myself, looking for things, stock photos is disturbing, it's frustrating. So with that being said, I'm just thinking maybe offline we can brainstorm some ideas of things to do moving forward. But I think that is important, and also including the community. So I think that's one of the things Philly did, but I think how important it was to involve people in the community, because a lot of times we do these things without including them. And it's like, how dare you come into my community and try to do these things without involving us? So
Right. I would say look at, formula companies have the manual on this. If you look at their imagery, you will see a variety. They target to everyone they want to reach. There's a commercial for them. There are commercials specifically for Black families that are formula based. They have them for Asian families. They have them for everybody. They target their audience, and we are not doing a great job with publicly doing that. And I love that Philly had them on bus stations and on billboards, and that offices could actually order supplies of their products to give out to their families, so they could put posters on their walls, or they could give them handouts. And I think it's really, really important to begin to change that narrative and shape it differently.
Absolutely. Thank you, ladies, for both highlighting the importance of changing the narrative and amplifying that message. Super important. So thank you for speaking to that.
And Christine, we have a few questions from the audience. Do you think now's a good time to ask one of them?
Absolutely.
Okay, great. So I will direct this one to Nasheeda. And we have a question that says, my daughter isn't pregnant yet. How can I begin to encourage her to breastfeed? Should they wait until she becomes pregnant, or should they start now with this messaging?
I always say the earlier the better, because, and I also say if it's a person especially close to them, there's different things that you can do as far as helping to encourage a person to breastfeed, and really begin to ask, those questions, or even find resources on your own about how you can help to support that person on their journey. A lot of times that's what happens, where people think, oh, well, I'm pregnant, I should just wait until later. And you can get so much more information out of it if you learn some stuff ahead of time before you deliver. Because I always try to tell a lot of the families that I work with, it's better to be prepared just in case these situations happen. So that way, you have some idea of some of the things that could potentially happen to allow you to maybe be more informed and think about the decisions ahead of time.
Great, thank you. So yes, start now, right?
Yeah.
And Christine, did you want to take our next question?
Sure. We have another question from the audience. Says, how does COVID-19, or does COVID-19 have an impact on breastfeeding? And will I be able to breastfeed my baby in the hospital? Also, if I test positive for COVID, can I give it to my baby? And I'll ask that to Dr. Davis.
Sure. So COVID has definitely changed a lot of the dynamics of what birthing would naturally look like in that entire experience. And I am thankful that some of those restrictions are beginning to be released, and people are really starting to pay attention to the CDC guidelines. So there definitely are guidelines that state that positive or not, that is not a reason to separate the birthing parent from their child. You cannot give COVID through breast milk. Right now, the evidence that we have tells us that that's not possible, but transference from parent to infant is still possible. And so when you are choosing to breastfeed, that we encourage you to wear a mask. And then the recommendations really state, try to have someone else be involved in the care. I don't know that that's always realistic. A lot of families don't have someone else that they can give care to. So really just practicing good hand hygiene, wearing the mask until you have a negative result. But you need to be able to be with your baby. So you can still do skin to skin, you can still breastfeed. All of those things haven't changed. Should you be someone who is positive when you go on to deliver, because many hospitals are testing to determine COVID status. You should not be separated from your baby if you have a positive COVID status, and that is part of the CDC guidelines.
Thank you for that.
Great, and we have a lot of questions coming in, so I'll go to our next one. Our next one says, can you talk a little bit more about milk banks? What are they? Are they available in Black communities? And what are some of the myths around Black women using milk banks? And I will start with Dr. Davis.
So I can say that in New Jersey, I am not aware of any community milk banks that are available, but I will say that this is why we have begun the conversation with Mama Hakima, so that that becomes an option and that's available. So there is difference between community milk sharing versus milk banks. Community sharing is more just women of the community who are offering their milk, and it's stored and supplied, versus milk banks that go through a different screening process, and there's usually a fee. So if you want to buy breast milk from a milk bank, for example, I believe it's something like $5 an ounce. It's very expensive. And so the thought of community milk sharing is to decrease that type of inequity that's involved in accessing it, but then also having more resources available to families who need it. So it's not my area of expertise yet. I'm looking very much forward to having this talk with Mama Hakima so that I can learn more about it. But I know some of the negativity surrounded by milk sharing is that we don't know, for example, whether someone is using drugs, for example, or if that person follows a special diet that you want to be on. And I think that the difference is screening. The same way that we screen for doing blood transfusions, breast milk is pooled and it's sterilized essentially that way, so that and everybody who donates is screened. So there is a process of safety that's put into place. But it's not nasty. That's often what I hear is, I'm not giving that baby that woman's milk. That's nasty. That's gross. It's not. We have been doing that for years. Our breast milk fed this nation. And so it's not something that's foreign to us, but we've gotten really far away from it. And so I think we just need to be open to hearing the information. If it's not for you, it's not for you. But I always feel like an informed decision is the best decision, and you can't really make an informed choice if you haven't learned about it first.
Absolutely. And Nasheeda, I see you shaking your head, so I just wanted to check in South Jersey, are you hearing some of those same myths, or what do you hear with your families?
To be honest, I will say that with a lot of the moms that I've worked with, a lot of the conversation has not been had. And I think that is important for us to make sure that we talk about it. A lot of times, those conversations aren't even being brought up. It's usually just breast milk or formula. And I go back to talking about what I said earlier about just being able to share all of the information and letting people know that they have options. So I think for me, that would be the biggest thing. But in terms of like people who I know have milk share, I do know some people personally who have done it. People don't always talk about it, but just know that it does happen.
Absolutely. And Christine, I think that's what you and I are hearing as well, right? It's happening. So, the conversations need to happen too.
Exactly.
And I think there's just, misinformation about how the breasts function, and how, everyone thinks that everything you ingest goes into your breast milk. And that's not necessarily true. The breast milk is very tightly protected. There are junctures inside the breast milk that prevent bad things from getting into the breast milk. That doesn't mean that it's, completely that nothing can get through, because there are some things that can get through. But for the most part, human milk is very protected in that way. And so that even if someone isn't following the best diet, we know that the milk is still going to be of extremely good quality.
Great to know. Very good facts for breastfeeding. And we have another question that rolled in. It says, my partner is breastfeeding, but I want to also bond with the baby. Is there anything that you could recommend?
Definitely.
Yeah. I was going to start off with you, Nasheeda, so you go ahead and take it.
I was gonna say skin to skin is a huge component. A lot of times, and this is specifically for partners, often feeling like I don't know where I fit in this, because a lot of times it's usually looked at as, you know, something that the birthing person and baby does together. So it's a lot of times something like I don't know where to begin or how to help or support. So there's different things that I always try to encourage people to do. So one of them is definitely skin to skin, because skin to skin doesn't mean that it has to be with that one birthing person. It could be done with other siblings. It can be done with a partner. It could be done with an aunt or you know, a brother. So just knowing that the skin to skin provides benefits for baby and for that person as well. The other thing I wanted to say, as far as like doing other things that could be just like as simple as, you know, changing the diaper and holding the baby and, you know, washing the baby up. And just having those opportunities at night to be able to do some stuff after that birthing parent has nursed them. It could be just burping, rocking. So I really say that although people may feel like they may not be able to do something directly when it comes to feeding, there's so many other things that they can do to help with bonding with the baby.
Awesome. Thank you, Nasheeda. And Dr. Davis, did you have anything to add as far as bonding goes?
Yeah, I think feeding is definitely something that everyone wants to be involved in, right? But like Nasheeda mentioned, there are several other things that you can be involved in, and I think it really breastfeeding looks different from every family, and this is something I meant to bring up as a barrier. Breastfeeding does not mean directly from the breast. Exclusive pumping is still breastfeeding, and there are families who, because they want the father to be involved, that they choose to do some pumping so that the father or the partner is able to give some bottle feeding. There's nothing wrong with doing that. The baby is still receiving human milk. So I don't want anyone to feel like they need to be dictated to of what their breastfeeding journey should look like, because it's going to look different for every family, and what works for one family might not work for others. So if that is like really important to them, that is another way that that could be supported. But we could also talk about the other things that they could do to be involved. So it doesn't mean that that family member won't develop a bond with the child because they aren't involved with the feeding. That is typically the birthing parent's job. But if it really is important for someone else to be involved, you could definitely pump or hand express some milk into a bottle and allow them to do it that way as well.
Thank you, Dr. Davis.
Great, thank you. So going to our next question, we have, can you talk a little bit about the sexualizing of breastfeeding and its impact on the desire to breastfeed? And Nasheeda, I'll start with you.
So when it comes to sexualizing, I think when we were talking before, as far as like the media has played a huge role in it. I think that there is a lot of things that we need to do within our communities to help to change that. But as far as providing support to families around it, I think is no different than what you would do with any other person. Just having those conversations and really getting to know what that individual wants, and then working towards that plan. But yeah, I would love to hear what Dr. Davis has to say about it. I'm just curious.
I feel like there's so many avenues that sexualization could take, right? There is the exposure of seeing breast. There is the actual sexual experience that's involved, because, let's face it, these are people who became pregnant. And so there's definitely going to still be sex as they are lactating. And that's a whole, different component of the sexual aspect when it comes to giving human milk. So it really is it's going to be different for each family's dynamic. And I think Nikki Greenway Hunter does a really good talk about breastfeeding after dark, which kind of covers that whole sexual experience when breastfeeding, because that is a taboo topic, and it's something that people need not be afraid of. Sex is part of life. But the other thing is, I think we know about the exposure of breastfeeding, and I think what's happened in Black communities specifically is a lot of women have expressed feeling almost shamed if they breastfeed in public. Some people will make lewd comments, and so there's this want to kind of just to close everything up. But then there's the other thing of the hypersexualization of the Black body in general, that Black women are often told to cover up or develop faster than others. And so they're getting unwanted attention at a very early age. And that has caused women to really be turned off by certain aspects of their body because of the sexual harassment that they experience as a result of it. And the breasts are often a source of that negativity. So I think, it was a question that I didn't spend a whole lot of time thinking about until I had a family who expressed to me that she was having a hard time making the connection with breastfeeding the baby, that she would do it, but it just always felt wrong to her and she couldn't really figure out why. During that conversation, she expressed to me that she experienced some sexual trauma that involved her breast. And so that history of abuse made breastfeeding feel very weird to her. And it wasn't until she was able to have that conversation about what her experience was that she was really able to make peace with it. And she continued to breastfeed after that. But there was a block there that no one really had discussed. And so because of her, I've added that question to my intake form. I asked about sexual trauma and that history because it does play a role in how successful people will be on their breastfeeding journey. And so again, when we're pushing people to breastfeed, these are the things that come up. And so we need to be very mindful of when someone is saying no, that we need to respect no. No is no in any sense of the word. And so sometimes there is trauma associated with why that person is saying no. We don't know what their history is, but we do know that the rates of sexual abuse in Black women are much higher than they are in any other population. So we need to use that as our guide again. And I mentioned trauma-informed care earlier, and I'm going to mention it again now. We really do need to be mindful with how we're working with these families and not just say, breast is best, because there's different things that come with that. This might be the family who chooses to exclusively pump, and that's fine for them to do it that way. They may decide to never breastfeed, and that is fine for them to make that decision as well. So I just want to really put that out there, that a lot of, in my personal work and what some of the research has shown is that people have become so forceful with breastfeeding that it has turned people in the opposite direction. That because they had these bad experiences with people talking to them about breastfeeding, although they were interested, the conversations that they had about it and the directions that they were given about how to do it turned them off to it, and they weren't interested anymore. So we just need to be very open-minded when we have conversations and respect people's decisions.
Thank you, Dr. Davis. A lot of what you and Nasheeda are sharing sounds like these can be very difficult conversations, to say the least. I mean, talk about trauma and sexual trauma and the history of racism and slavery and all these things coming together. That's a lot. So I just respect what you both do, and I'm sure that the moms and birthing people who are able to talk to you both really appreciate that as well. If there's and this is just my own follow-up question to that, but if there's a mom or a birthing person who does not have a lactation consultant that's maybe as aware of these things, but they want to talk about sexual trauma or why they don't want to breastfeed, is there a way that they can bring that up with who they're speaking to, or what would you recommend in that situation?
You mean the provider or the family?
For the family, if they're feeling all of this built up, I imagine there might be a lot of shame and fear, maybe even to ask. Do you have any suggestions of what they could do in that situation?
Well, I think part of caring for families is first establishing trust with that family. And so if that family does not feel comfortable sharing that information, I'd have to question what happened at the start of that relationship, that maybe trust has not been built and they don't feel comfortable with sharing that information. I feel how you approach families has a lot to do with the information that they share with you. If you become very judgmental or accusatory, which is often what I hear from Black families and working with white lactation professionals, is they feel that they need to direct people on how to breastfeed and what's appropriate and what's not. And so if that's how the conversation starts, that's how it's going to end. They're not going to get any more information. So I really feel like I am real big on empowering families to remove themselves from situations that are not serving them. Find somebody else who you feel like you can connect with. And I'm happy to say I am one of the the few Black lactation professionals in this work, but our state doesn't have many. And so that limits choices. If this is who your insurance is paying you to see, then you're kind of stuck with that person, right? So I think looking at the other resources, there are a number of Facebook groups that are designed as safe spaces for Black women. I think definitely seeking solace in those groups is really helpful. That peer aspect and support is wonderful. And sometimes you can connect with someone that we didn't know existed. So, sometimes I'll learn about, oh, this person does lactation work here. Really? I don't know them. Let me know them so that I can make referrals. So sometimes you get information that way, but I think you have to protect your peace in all senses of the word, and find providers that respect that. And if you find that you're having conversations that are not respectful and are not listening, because often the conversation is that you are being told what to do opposed to being asked what you'd like to do, that's the provider that you don't need to see anymore. I always say insurance is payment. Take your money elsewhere. You don't need to be with that person. So find who's going to work for you. And that might take some digging. That might take seeing a couple of people before you finally find the person that you feel comfortable with. But that also might come out of lactation as well. There is actually a colleague of mine who is out in Philly who is the lactation therapist. Her background happens to be in mental health. And so sometimes finding that connection is really helpful as well, that it might not come from a lactation provider. You might have to seek a mental health provider to really give you the support that you need, but don't be afraid to ask for those things.
I love that. Thank you. So finding a provider that works for you. I know we mentioned that with preterm birth too, and across the board with maternal and child health. So thank you for that recommendation. I see we're running out of time. This is such a rich conversation, but I see one more question I want to get to quickly before we plug some things and start to wrap up. Nasheeda, somebody asked, what can be done to introduce breastfeeding to children in a positive way? So maybe let's go there quickly if you have any comments for this one.
So introducing maybe older children or siblings to someone else breastfeeding, if that's...
It's not specific, so let's go with introducing breastfeeding positively in general. Does it matter whether it's an infant or other siblings or children?
I think no, but what I was just saying is the reason why I bring that up is sometimes with children, they can be a little curious. So just how you say things, as far as like and what you say, instead of ill or yuck or those kind of comments, I think sometimes can have those negative ideas. But explaining and being able to share stories and talk to children around breastfeeding as is natural, and it's something that is a part of what our bodies are designed to do, to help to begin to introduce that in a positive way. So going back to what I was saying before about like that shift and focus on a narrative. But one of the things that I remember, my son, who was 5 at the time that I was getting ready to have my daughter, and just talking to him about it and what he thought it was, and kind of, having that conversation with him about what it was that I was going to be doing, and kind of walking him through that process of what it would look like. And then also talking about, for me, like those experiences and how he could help and to support that. And so those times that I did pump, I would also allow him to participate in feeding. But just overall, just talking to children or just in general about it, I think that we want to make sure that what we're saying is more in a positive way, so that way children can see it as something positive and not necessarily anything negative.
Great, thank you. Mm-hmm. And Christine, I'll turn it over to you. That's most of the questions.
All right. Well, we'd like to thank Dr. Nastassia Davis and Nasheeda for being on our call today about Black breastfeeding and preparing us for Black Breastfeeding Week, which is next week. For more information on Black Breastfeeding Week, you can go to the website at bbwnj.org to learn more information. And also you can reach the Perinatal Health Equity Foundation website at Perinatal Equity perinatalhealth.org and visit Nastassia on social media at Perinatal Equity. Also, you could reach Nastassia at Camden Healthy Start. And last plug is for the Prematurity Prevention Initiative. Make sure you can reach us at NJ Preterm and visit our website at njpreterm.org. So thank you, ladies, once again. Thank you for all who attended this webinar, and have a wonderful day. Thank you.
Thank you all.
Thank you. Bye.